c'est de ta faute, c'est de ta faute.
Here?
Normally the moderator just sits.
Yeah. As you want, as you prefer. Do while you're comfortable.
Because then this is for the speakers.
Yes, okay. I will tell to the guy.
Dear colleagues and friends, a warm welcome to this lunch symposium about direct vision needlescopy. Is it the new standard of interventional procedures? I'm delighted to introduce to you the speakers, and the first speakers, they have one lecture, and that is Professor RIGOARD and also Dr. BOUCHE. We know each other a long time already. And they are both very much experienced in pain and in other treatments. And they work at the University Hospital in Poitiers. So the first lecture will be how can ultrasound guided microendoscopy help for optimal placement of neuromodulation devices. It will just give you an example of the possibilities, what you can do with the echo and the needle together when you can see actually what is at the end point of your needle when you go to the target, whatever target you choose, and you are in the vicinity, you can change the screen and see real time what is at the end of your needle. So, can I ask you to start your lecture?
Good afternoon. Bon appétit. Thank you very much for having us. We will deal in 15 minutes with this very passionate topic. My name is Philippe RIGOARD. I'm working in Poitiers University Hospital, which is a human-sized city close to the Atlantic coast, and we have the chance to work together with Benedict, my colleague, but also a best friend. And we have a nice facility to try to think about innovations and new techniques for the future of our patients beyond the historical heritage of Poitiers. Today's agenda is 2 minutes about philosophical concepts. I know that we only have 15 minutes, but I think it's very important to be very aligned. We're going to talk about peripheral nerve stimulation, and we're going to talk about evolution, I will say revolution, thanks to the use of 7-star scope. You're going to see that in a minute. So philosophical aspects. Please don't be too difficult with me. I'm just a neurosurgeon. So if we talk about ultrasound, I don't have any legitimacy here, and you are the professionals and you are the ones who can achieve and think about the future in this. So that's why I needed Captain Marvel next to me to talk to you about very specific aspects. But truth is, if we take the example of brain aneurysm, neurosurgeons, they wanted to do that for 50 years. And the future will not belong to anybody who is claiming I'm neurosurgeon or I'm radiologist. The future will come from hybrid OR with the two people together in the same room. It's coming from hybridization. If we look to spinal metastasis, this is maybe something which was very far from your topic, but now if you do interventional pain, of course spinal metastasis treatment is a mix of radiotherapy, interventional procedure, surgery, and this is about hybridization for sure. If you look to the future of handicap and surgery for handicap, this is a big topic for me. I was performing neurotomies and big scars 15 years ago. Now, with Benedict, we work together. She's an anesthesiologist in the OR, with Romain, who is a pain and a PMR, and who is performing cranioneurotomies on those patients without any incision. So, if you want to think about spasticity. So, I think if we come back to pain therapies, to the pain pathway, optimizing the pain pathway of patients, for sure, we need to combine our skills, we need to combine our visions, we need to work together, we need to have fun together. And that's, I think, the key, maybe the most important message of today, and this is about philosophy, not technicity. So now, if we move to the peripheral nerve stimulation, what is it? Because we saw that there is a topic on tracheostomy just after, so maybe you got a huge culture, but PNS, peripheral nerve stimulation, is something a bit specific. I'm sure it will be part of your future, but this is something specific. So just to put it in a nutshell in 2 minutes, the peripheral nerve stimulation is the first stimulation which has been applied on human after the torpedo with Egyptians. This is antique stuff. But the first stimulator has been put into human on a sciatic nerve in 1968. And it has been 40 years that pioneers like Giancarlo Barolat in Colorado, Denver, is putting leads in all the nerves of all the body and is a pioneer on this. So where the revolution is coming from? It's coming from the ultrasound. The fact that you got access to very high quality ultrasound now, and we can go and see this beautiful landscape beyond the skin thanks to this. So if we talk about PNS, I see the president of the Portuguese chapter, Mariano, at the first rank about neuromodulation, but we don't have the same practices all around the world. If we talk about PNS here during 12 minutes left, it is not subcutaneous stim. It is true PNS. It means that it's a peripheral nerve stimulation all along the nerve, targeting directly the nerve. Why? 4 concepts. Subacute pain. You can imagine to target the nerve very, very immediately after a surgical procedure, for example, or subacute pain, to reverse the chronification of pain, the plastification of the neural system, and to have a very portable device, which is not definitive, not permanent, but we can maybe take over the neuropathic, pathophysiology and avoid that. Second aspect, as a salvage therapy. You can think about putting peripheral nerve system. If, for example, a patient is implanted with spinal cord stimulation, it's not working, then think about PNS, brachial plexus avulsion. We're going to talk about this difficult topic in a minute with Benedict. Optimal selectivity, what it is? Optimal selectivity means if you apply to a patient a spinal cord stimulation or a deep brain stimulation for a very focused fascial pain or ilioinguinal pain or a pain in the saphenous area, this is rubbish. You need to think about something very selective, very, very specific to the distribution of the dermatomic nerve and nerve. And the last aspect is about the future. Before coming here this morning, we were in Walk-in Paris lab. This is a lab combining exoskeleton to restore the functions of patients, and peripheral nerve stimulation will be, of course, once again, an hybridization to restore some mobility of the patients. So look at you, my friend. You were an anesthesiologist a couple of years ago, and now you are thinking maybe about restoring function through peripheral nerve stimulation with interventional pain and rehabilitation medicine. This is in your hands. I'm so happy to share that with you. The future will not belong to neurosurgeons. It's over. It belongs to you, anesthesiologists. You are the ultrasound guys and professionals, and I think there are wonderful topics to deal with. So it is all about anatomy, of course. You have this GPS, which is the combination of the 3D vision about what's beyond the skin thanks to ultrasound and your anatomical knowledge. If you apply that to brachial plexus, of course, Yesterday I was operating a tumor of the brachial plexus on a lady. It's difficult for me to go over there. But with ultrasound, in 1 minute, you can be in C4 at the bifurcation of the carotid artery or at the Chassaignac tubercle in C5 or C6. And then when you don't see the tubercles anymore, you know where you are, you know the vertebral artery, you know exactly what's going on, and it takes only 1 minute for you to do that. So putting that into a nutshell, I think that if you apply the ultrasound to PNS, you can achieve wonderful stuff, much better than I did by the past. Look, this is a surgical lead with a scar of this to target the ulnar nerve with some lead to stimulate the patient. This is rubbish also. Now Benedict is the lady who is taking charge of those patients in our unit. She has the ultrasound knowledge. In 2 minutes, she can think about putting 0.5 mils of lidocaine to target the neural nerve, which is the problem. Then apply pulse radiofrequency or those kind of stuff. And then if it's refractory to this interventional pain medicine, then think about neuromodulation by putting the lead under ultrasound exactly at the same place, with the same technique, with the same devices. So I think this is something very interesting to consider, that you have the ability to change the world and to change the future with the median nerve, with the suprascapular nerve, a big target for shoulder pain, with the cervical plexus for a lot of patients who are complaining about cervical brachialgia, but this is a problem when they are swelling, and this is a problem coming from the cervical plexus. So after you dissect the pain and the origin, you target the pain with the needles, you apply pulse radiofrequency, and then you think about putting a lead to get a permanent effect on for the rest of the life of your patients. I think you are doing a good job, and I'm encouraging you to think about that. So if you think about brachial plexus, not only target but simulation, peripheral nerve simulation, you can use the ultrasound and have a wonderful target here. Neurosurgeons, they claim that we can do motor cortex stimulation, putting needles in the middle of the brain for people who have chronic headache or pain in the lower limbs. That's rubbish. I will never encourage my father to go for this if he has a pain, I mean a fascial pain or a pain in the body. There is much better today. I don't understand that. I will send my father to Benedict, of course. And Benedict, as you are probably in the room, somebody who is a professional with the needles and who is performing all those kind of stimulation that you are familiar with. But at one point, if we think that we can target the lateral femoral-cutaneous nerve, if we can target the saphenous nerve in a minute, at one point, we need a revolution. We need something better to fight against the people that claim that for the peripheral nerve stimulation, if you are not so close to the nerve, you spread energy and you need high energy requirements. It is difficult to get these skills because you are blind and you don't see exactly, even with ultrasound, the reality of the anatomy. You know that. So if you add something to clarify this vision, you can change and improve your patient outcome. That's what Benedict will tell you about in the last 5 minutes. Thank you very much.
Thank you, Philippe. What is it, EvoTouch with 7-star scope? Is a device. This device combined fiber optic fiber pass through small needle with ultrasound. You can switch one view from view to another view in same screen. It's very interesting. You have direct view of your target with 7-star scope. For example, it is brachial plexus stimulation with PNS. At the beginning is the same as another technique. We begin with shows your good target. For this patient is C5, C6. The needle is introduced with ultrasound ultrasound guidance when you are close to the target. We put the optic fiber and we can see the structure. We need to hydrodissection with elastomeric pump. We can recognize the nerve with like a blue tissue surrounded yellow flat border. You can see right structure. This right structure is probably aponeurosis or fascia, and the red is probably muscle. Now, you can't see directly the position of the lead with this device now. So, at the end of the procedure, we check, like another technique, the good location of the lead with ultrasound. This case is a patient we implanted with Philippe in January during a live session in European Congress. It's very great experience. It's a very complex patient, complex with failure of spinal cord stimulation, complex because is high level sports patient. Now I give the word back to Philippe.
Thank you very much, Benedict. So I don't know if you are all familiar with pain, but it is amazing to see that with peripheral nerve stimulation, you can rescue somebody who has been implanted 3 times in another city with spinal cord stimulation on a CRPS, and which needs a wheelchair to leave, and that at the end with I would say 2.5 minutes procedure under ultrasound plus optic fiber, this guy is running back and is very happy to be back on track. So in the last 2 minutes, we're going to present to you, the first results of our preliminary experience. Of course, guys, this is not to provide high-level science. This is just a preliminary experience about 8 patients and 6 here in this series. This is a pilot study. This has nothing to be, like a randomized control study. We need to work together to improve our knowledge about this device. But it is to show to you that compared to spinal cord stimulation that I'm implanting every day, now when I got a CRPS patient, I don't implant SCS spinal cord stimulation anymore. I send the patient to Benedict because I think that you are not taking the risk of spinal cord injury, CSF leak, big technology in a very mobile region, and Benedict with ultrasound and optic fiber is able to do much better than I do with something which is very specific and which consumes less far energy. I'm gonna show that to you in the last 2 minutes. So we had the primary objective to see if it was feasible to combine all those techniques. Here are, and sorry for the purpose of time, I cannot insist, but we will be happy to address any question about that. But here are the criteria. That was patients with refractory chronic neuropathic pain with a peripheral distribution and with refractory to any medical management. We apply the treatment and strategy, and we try to do a lot. We do a lot of research in my lab, and we apply the classical criteria of the assessment in pain. But something very unique is not only the VIS, because when you are receiving a patient in consultation, he has got back pain, but also a migraine. You asking him to fill the VIS in the study, he's putting 9, but it's not about the back, it's about the migraine. So the idea is to combine all those stuff into a composite index which has been published and patented, a multidimensional clinical response index, taking all these components of quality of life, anxiety and depression scale, perception of change, VIS, topography of pain with objective quantitative measurements, and to determine what's the outcome, the real outcome in multi-dimensions of these patients. So as you will see for these 6 patients, and once again this is very preliminary, but the VIS decreased amazingly. That was very encouraging. The MCRI, this composite index, is doing much better for those patients, as well as functional outcome, as well as EQ5D, the quality of life, as well as the decrease of pain surface, and as well as the patient satisfaction. Of course, it's 100% patients. We don't like that in big studies, but this is preliminary experience on very selected patients in a team who is experienced. So it's just to show you that there is a benefit here, and we never had to deplore any complications compared to spinal cord stimulation. So, one last slide is about the energy consumption. Can you imagine that with optic fiber, you deliver, this is a computer modeling, 1.8 microcoulomb per second in terms of energy to the structures to get the effects. You need to multiply this by 3 if you don't have the proximity of the nerve, thanks to the optic fiber and 7-star scope. And this is 100 less than the spinal cord with high dose in terms of energy. Look at the future of the Formula One. It's coming from the batteries. And that's something very important. So in conclusion, I think the future of neurostimulation will be the peripheral nerve stimulation. But not only the ultrasound peripheral nerve stimulation, we will call that OFUS guided PNS. This is optic fiber and ultrasound combined guided PNS to increase the proximity and the patient outcome of all the pain chronic patients, thanks to this revolution which belongs and which is into your hands. Thank you very much for your attention.
Thank you very much.
Thank you very, very much. There is time to take questions after the lectures, if you don't mind. So I'd like to thank you again and to introduce the next speaker with a totally different subject. And we are happy to present Dr. MSHEIK from Lebanon, who is going to tell us how microendoscopy can make a difference in percutaneous tracheostomy. I think this is an important issue because in the corona time there were a lot of accidents, a lot of people on artificial ventilation, and there were also a lot of accidents and false routes and emergency intubations, etc., etc. So this could be a great help.
Presentation to work. Hello everyone, good afternoon. I'm going to be presenting today a new topic. It's a microendoscopic ultrasound guided percutaneous tracheostomy. It's different from the usual scenarios that we use for performing trachs. So basically I'm an anesthesiologist and a critical care consultant. I work in Lebanon in the Central Military Hospital. I'm also an attending of surgical ICU at the American University of Beirut. And so I will be presenting for you the background and history regarding tracheostomies. Also, we're going to discuss the current methods and risks with the current percutaneous tracheostomy on a short notice. Also, we're going to talk about the microendoscopic ultrasound-guided percutaneous tracheostomy. We'll divide the topic into 4 parts. So, description of the technique. I'm going to show you images and video of the technique. We'll talk about the benefit and the drawbacks, and finally, the conclusion. But before we continue on, so I have a couple of questions to the audience. Who of you have done a percutaneous tracheostomy? By raising hands. Okay. What do you use? Which method do you use? Ultrasound, bronch, or anatomical? Combination of ultrasound and bronch. Okay. So background, first description of the tracheostomy appeared in all the Hindu scripts. It's around 2000 years before Christ. And also in Egyptian documents like 1500 years BC. Tracheostomy can be a life-saving technique or a treatment procedure. Tracheostomy is done now in 2 methods, so it's either surgical or percutaneous, and it is by far one of the riskiest procedures done in ICU. The origin of percutaneous tracheostomy is unknown. However, the first description was with an Italian surgeon by the name of Santorius, who described it first in the 16th century. The second description was by Sheldon in 1955, who described the percutaneous tracheotomy. And the final and the most common used method, it was devised by Sigalia, which is the percutaneous dilation to percutaneous tracheostomy. So the current methods, as have been proposed before, there is a single-step dilation percutaneous tracheostomy, which is the most common technique. We have the anatomical, we have the ultrasound guided, and we can do bronchoscopic guided, or we can combine together the anatomical with the bronchoscopy or the ultrasound with the bronchoscopy. Now, the drawbacks of the current techniques. So if you're dealing with bronch, then you have to occlude the endotracheal tube. This will cause CO2 retention, desaturation, will increase airway pressure, which may lead to barotrauma and pneumothorax on patient. If you're doing it anatomical, so by palpation, you're at a risk of bleeding. Okay? If you're using the anatomical or the ultrasound, you're at a risk of airway loss. And airway loss happens through puncture of the balloon of the endotracheal tube, or by manipulation of the ET tube, which can dislodge during the procedure. Also, during the COVID, you know, the exposure with the aerosol and the virulent particles, so you're increasing, if you're doing the bronchoscopy, you're increasing the exposure to aerosol to the whole personnel that are in the field with you. Also, with the bronchoscopy, it costs much more than the rest of the procedures. So our technique, it's a single port entry. It uses real-time ultrasound imaging and real-time endoscopic imaging. So first we start by sterilizing the whole field. We sterilize from the angle of the from the mentum till the nip line. We prepare all the required items from the percutaneous tracheostomy set to the local anesthetic with epinephrine. You can either sedate the patient with sedation and anesthesia, or you can use also an extra of muscle paralysis. It depends upon your experience and your what do you expect from the patient and the behavior of the patient. So our first step would be scanning, a longitudinal scan of the neck. The structures you're going to see first would be the cricoid, which is the structure labeled as A. This is the identified landmark for the start of our technique. Then you will see the rest of the tracheal rings, which are going to appear as beads on a string view. We usually do the percutaneous tracheostomy either between the first and second tracheal rings, or the second and third. So here then we localize the space with a needle, a 22 gauge needle, which we slide under the ultrasound, and then with a surgical marker pen we localize the area that we need to prick. Then we do a cross-sectional view to make sure that we don't have any arteries, any veins, any important structure in our field. And then you can see the advancements of the needle, the angiocast, it shows as a black structure. And then upon advancing, once we reach the anterior wall of the trachea, we do some hydrodissection, and you can see at the left upper corner of the image, you can see a small image. At this step, we will shift from the ultrasound view to the real-time endoscopic image, and you're gonna see this view. This is an actual view from the trach, which is the intratracheal ligaments. This is with hydrodissection. And this is a video of what you're going to see in front of you once you're pricking the tissues. After that, we're going to pass the tracheal wall. So once you want to do this technique, you can do it either two ways. I have done it in two ways. So either you withdraw the endotracheal tube up, or you keep it in position. Our technique would help if you keep the endotracheal tube in position. You're going to be able to see the balloon. And in the current videos, I will show you some of the image inside the trachea. So this is the endotracheal tube. You see it on the, excuse me. When will IT? I need the IT, please. Stop. Yep.
Space bar maybe. Yeah, there's a space bar. Because this is not the same slide on the screen.
We need the IT. No, the image is stuck. We're having a problem with the IT, so the images are stuck. So basically, to keep on going, so what we do in the tracheostomy, you can either withdraw the endotracheal tube up, or you can keep it in position. And then while advancing, because you have the aid of the micro-endoscopy, you can actually see the balloon, you can actually see the ET tube. And in the coming videos, I will show you the images. You can see it, and then this way you will not, you will guarantee not losing the airway, so you'll not puncture the ET tube balloon and cause any leak or air leak or desat in the patient. And the nice thing about doing this procedure is that you can take the whole time you need it. So for junior residents or fellows or anybody trying to learn the percutaneous tracheostomy, you can take 1 hour doing this procedure, and your patient is not going to desaturate, you're going to not see any CO2 retention, you're not going to see any change in airway pressure at all. Unfortunately, the slides are stuck. I can't hear you well, sir.
الفيديو كمبيوترك اعمل هاك داون وشغل الفيديو من المحل اللي انت حافظه.
Yes, Symposium.
عرفت؟ هذا بيكون اللينك معلق.
This is, yeah. This is not.
You did not give the source. So you give the PowerPoint, but not the source.
Yeah.
Now it's looking to your computer. The move is on your computer, not that.
Not this one. The one after. Yeah, you need to go on the slides. This is the previous slide.
Ah, c'est le Pavlov. Okay, need to use this one.
Okay.
Okay, and to swap, I think.
And
to
how do you go forward? We need to stop the video now and go on. Alex, I need to stop the video. Okay. So basically, now you can see the view inside the trachea. You can see the ET tube to your left, and this is from inside the tracheal wall. And the second video is an actual, so once you insert the rigid stylet, the metallic stylet, I usually withdraw the metallic stylet outward, and then I recheck the position by inserting the camera into the soft angiocath, and you can see again the image. So you can see the endotracheal tube, and you can see the tracheal wall from inside. It's not, yes. So these are a couple of images, like I have told you, either the technique, either you withdraw the endotracheal tube or you keep it in position. So the first three images are the endotracheal tube is withdrawn. The other three images, I have the endotracheal tube in position. I didn't have to use it because I can see I have vision in front of me, and I can't prick the ET tube. So this is a view of the carina. This is the final view that we can see it. Now play. Faster. So on the left side, you can see the carina. This is the actual view. So this is once we put in the tracheostomy tube, you can easily go with the 7-star scope into the tracheostomy tube, and you can see the carina to confirm the position. Okay, So the benefit of the procedure, as I have told you, it's less risk of bleeding because currently you're seeing with the ultrasound, you can see any artery, any vein in your path. So this will lead to a less risk of bleeding. Also, less exposure to aerosols because, as I have told you, you can see easily the balloon. It's a small port entry. It's a single port of entry, which is a 16-gauge needle. So there's not much exposure to aerosol or to the gases inside the lung to the environment. It can be done in an emergency situation with 100% certainty. And to this note, I don't know if any of you have tried to do a percutaneous tracheostomy or a cricothyroidotomy on emergency. Okay, how do you feel on doing it? You will lose all the skills, even if you're an expert, you're gonna lose all your skills. So we're adding a definite another source of verification, which is the visual field. So ultrasound with visual field, you will be 100% sure you're in. Okay. And as we said before, less risk of desaturation, less risk of CO2 retention, no need for a change of endotracheal tube. And one of the most important aspects to me, it's plenty time to teach junior residents and junior physicians on how to perform this procedure with ease and with 100% certainty. So drawbacks, the only drawback I found compared to the bronchoscopy is the narrow field of view. Thank you guys, and if you have any questions, we'll answer them later.
Thank you very much again, Dr. MSHEIK. We go on with the next speaker, my good friend, Dr. RIZK, also from the Lebanon. And he is the head of renal anesthesia and pain management division at the American University at Beirut Medical Center in Lebanon. And he will give a lecture to show the advantages of endoscopy combined with fluoroscopy for interventional pain management.
Thank you, Rob. Always a pleasure to be with you. So thank you everybody for being here. My topic today is about ultrasound with the endoscope for transforaminal steroid injection. So first I'm going to present the technique, and then we'll discuss the comparison between the regular technique, the gold standard, CT-guided, fluoroscopy-guided versus ultrasound. So as you all know, with the advances in ultrasound-guided techniques, in pain management, pain interventional management, we're using much more the ultrasound in much more techniques. But in the spine, we have a lot of limitation with the ultrasound. So still, fluoroscopy and CT scan are the head. Most of the interventional pain management would prefer doing their procedure under CT guided or fluoroscopy. I hope I can change your mind. So first, this is a publication where they compared the ultrasound guided versus the fluoroscopy guided transforaminal steroid injection, and they found that the ultrasound is lacking behind for safety and for accuracy. So this is another publication where, to decrease the radiation, they did prefer doing their procedure under MRI than on CT, knowing that MRI is like double the price of a CT. Definitely ultrasound, it's much cheaper, but it's lacking behind for safety and for accuracy. So most of the publication you can see over the internet, the accuracy of ultrasound guided steroid injection is around 85 to 90%, and who would accept a 15% failure rate? So this is another publication of Dr. Naruz, and he concluded, while doing his technique, he did a cervical transforaminal steroid injection, then checked them by X-ray. He found that the tip of his needle was like at 5 millimeters from the targeted point. So there's no that accuracy. And he concluded that with the ultrasound, you need a randomized controlled trial to compare the effectiveness and the safety of the ultrasound. So it's always accuracy and safety. We're lacking behind with the ultrasound, with accuracy and with safety. So this is another review where they found also that you need to check your tip of your needle with fluoroscopy. You cannot do it alone it's not safe to do it alone with ultrasonography. So if you look over the internet, you can see many techniques, like they were checking for the accurate placement of the needle with nerve stimulation, with ultrasound, with CT guided, with MRI, and trying as much as possible to be as accurate as possible. But they concluded that ultrasound alone cannot do that job. They started talking about ultrasound guided, fluoroscopy assisted, or ultrasound guided, CT assisted technique for nerve root injection. So this is the last review published, the latest review being published, and also they found that ultrasound is lacking behind, and there is no publication. That technique was like described in 2005, and still for the last 15 years there's no publication about the safety and the efficiency. There's no advances in techniques about safety and efficiency. So everybody talked about that. This is the new device where you have a screen divided, a double vision screen. You have a dual image on your screen. One side is the endoscope, the other side is the ultrasound, and you have the needle with the scope. So you have, with the ultrasound, an outside vision. You're going under real-time ultrasound, seeing the hub of the needle, okay? And you have an eye at the tip of your needle for checking for safety and for accuracy. So now we're safe. We have safety because we can see real-time, and we have accuracy because we can make sure that we are inside the foramen. So what is the technique about? Galliano first described this technique, then Gofeld described this technique. You go with your ultrasound, you visualize the facet joint, then you move upward to see the lamina, which is the tightest area. Should be careful when you go up on your spine, it's going to be narrower and much more difficult to see the lamina. So then you just put your probe like this, and I'm going to describe it as you can see it here. So first we start looking for the level you need to inject. We start by the sacrum, and we start counting. This is L5, the narrowest, then L4, then L3. Once you have the level you want to inject, you just turn your probe in a transverse approach, in an axial transverse approach. And this is what you're gonna see. This is the interlaminar view. You see the facet. We don't see the Batman sign a little bit because we're focusing over the facet. So we start scanning the facet up to see this. And this is where you see the arrow. The arrow is the lamina. This is the needle going next to the lamina. So we numb the skin. We go with our needle next to the lamina. We use our needle as an introducer for the scope. Once we're at the tip of the lamina, you're at the intertransverse ligament. And this is what you're gonna see. This is the ligament. A lot of people try to do it by loss of resistance. But this is dangerous because you know that the disc will distort the anatomy inside the foramen. It might push it up, push it backward, and underneath the ligament, you might have the artery, you might have a nerve, you might injure them. So once you're at the intertransverse ligament, we have our scope in, and we're gonna visualize the artery. This is the artery there. And you're gonna see the artery pulsating. You're gonna be sure, 100%, that this is the radicular artery. And you're sure now that you are in the foramen. So having accuracy a problem, having safety a problem, now with the endoscope, we bypass the accuracy. We're sure that we are in the foramen, and we're sure we're not puncturing a vessel or the nerve. Even CT scan or MRI, you're never 100% sure that you did not puncture your nerve. So with this, you can see your nerve, and you're 100% sure that you're not puncturing your nerve or puncturing a vessel. So we started with 7 cases, uncomplicated cases. All of them were having radiculopathy, back pain, disc problems, and we needed to inject them. We did them with the micro-endoscope and the ultrasound guided technique. We were able in all 7 cases to see the radicular artery, and we were sure that we did not puncture any vessel or having any problem. To make sure that we are in the foramen, we did inject some dye and check them by fluoroscopy. And once you see the artery, you're 100% inside the foramen, and you can see that the diffusion is excellent and there's no extravasation outside the foramen. So with the pilot study, we looked at the Roland Morris before the procedure, at the end of the procedure, 3 weeks later, 3 months later, and we followed up our patient up to 6 months. And the results were like comparable to the fluoroscopy, were almost the same as fluoroscopy. Patients were very satisfied. During the procedure, even though the needle is 18 gauge, there was no pain. It was almost the same pain scores as if you're doing it by fluoroscopy at a 22 gauge needle. Time of the procedure was much smaller. The problem, we were not like used to this technique. We had some time to prepare the endoscope, the sterility, things like that, but usually it should not take that big problem. We didn't have any complication in those cases. Now we're conducting a bigger study comparing the ultrasound on microendoscope to fluoroscopy, and if our technique is non-superior to the fluoroscopy, we have a lot of advantages. First, there's no radiation with the ultrasonography, and this is an absolute indication in pregnant patients and in children. In those 2 populations, you cannot do a transforaminal steroid injection unless with ultrasonography, and the safest is to do it with the ultrasonography with the microendoscope. Definitely, you decrease the risk of anaphylaxis of dye because you need to check with the fluoroscopy with dye. With this one, you don't need it. You also bypass the kidney injury, if any. You don't need the hospital setup at all. You can do it in your clinic. You don't need a big setup with a CT scan, with a fluoroscopy. There's definitely less risk of nerve injury, even with a CT scan. With a fluoroscopy, there's always the risk of injuring a nerve. Here, you don't injure the nerve because you can see it. Less, definitely, vascular puncture. A lower cost. The cheapest is the ultrasound. Decrease average time because you don't need to recorrect your needle. Under fluoroscopy or CT, you always adjust. Under ultrasound, you go a real time and you don't need many attempts to readjust. Definitely, you need to train on this, but definitely you'll be confident because you'll be seeing. You'll be confident to advance your needle. So you can also grade the severity of the nerve compression and correlate the outcome of the patient with the nerve compression. So the other research plans we're working on, nowadays the grading of the stenosis inside the foramen is done under MRI. We'll try to do it under direct vision by our scope. So you know that's not only the fragment which is compressing, it's the edema around the fragment which will be compressing the nerve, and now you can see the edema, you can see the compression, you can see the deviation of the nerve. And we're gonna try to correlate this compression with the outcome of the patient. If this compression is so, the patient will be helped that much. So also other future application, maybe doing it for the dorsal root ganglion. You'll be confident and safe to do dorsal root ganglion rhizotomy if you go inside the foramen with the scope. Also definitely using it in the cervical area where you can move on without puncturing vessels. For me, this device is like a transition from the black and white view to the colored vision. So thank you very much. Any questions?
Thank you, Marwan, for this excellent lecture. I'm delighted about this. And now there is time for some questioning, and then I will ask the speakers to sit down here. And Then I look at you, and is there anyone who wants to question about one of those topics?
Hello, my name is Sandra Schiens. I'm not involved at all in pain anesthesiology. I'm involved in obstetric anesthesia, and I've been tremendously interested in visualizing an accidental dural puncture. Will this device provide opportunities to see what's going really on inside the epidural channel?
Yeah, the introducer needle is a cutting needle. It's not a Tohi needle. Because we cannot go with the scope inside the Tohi needle. It's going to deviate up. So we didn't try it. We didn't do an epidural with this. But I think we can do, under ultrasound guidance, epidural. And I'm going to soon publish a spinal transverse versus paramedian approach real time with the device. So maybe doing it under ultrasound guidance with the introducer we have. But I'm not sure about the loss of resistance. We should be very careful.
But maybe in the hands of an expert.
Yeah, I would try it if I put the scope in and pass through the ligamentum flavum under vision.
Yes.
And maybe, yes, we can see if we are at the same level, we can see the dural puncture.
I know from Flores there is one case where there was some visualization.
Well, I can assure you that, this device is quite new, and with the corona, of course, the use of and introducing of this device was a little bit delayed. But I assure you, Marwan, that it is used. I did it myself, epidurally. And there is a hospital in the Netherlands that is trying now to set up for the thoracic epidurals training. And the Toei needle is not a real problem because the fiber optic depends on, it is 0.9 millimeter, but there is also a fiber optic is 0.6 millimeter with 10,000 pixels, and that goes around the curve a little bit. The only thing is now that there is a little bit reflection of the light. So what you actually see in a Toei needle, you see on the bottom like a moon, yes, because it cannot go through it. And then on the upper part, you see excellent pictures of the epidural fat that's coming in. So you introduce it without loss of resistance. You can just push it forward. You will, if you are experienced, you will feel, of course, the ligament, but you don't need it. You see it. It's very white. Then you puncture it. Then you see the spinal cord. You can, the dura with the nice vessels on it. But the epidural fat is coming to you like diamonds. I mean, it is a fantastic view. And I can show you the pictures where we introduced the catheters on a lower level and we were finding them on a higher level, you know, just to show that it is possible.
Thank you. Beautiful presentations. Can I have a question to Benedict? Because I'm sure you ventured further than the big nerves. How little nerves can you see? Can you give us examples of how far you can go, lateral femoral cutaneous or deeper, smaller?
Yes, with stethoscope? With stethoscope or only
Yes,
ultrasound?
no, several stethoscopes, of course.
I do ilioinguinal, cutaneous lateral femoral cutaneous.
You can see them nicely.
Yes, I can see. I can see to hypogastric, inferior hypogastric plexus. I do suprascapular nerve, beautiful, very easy. Axillary nerve,
Yeah,
very easy. Right.
Fantastic. And can I have one more question? When you place your stimulators, do you place them parallel or perpendicular to the nerve?
Depending on the nerve.
on the location?
I prefer parallel of the nerve. I prefer parallel of the nerve because I have some contact for the stimulation. But in brachial plexus is
impossible.
Impossible.
Yeah.
But lateral cutaneous is no problem. Ilioangular is no problem.
Thank you so
on the
much.
nerves.
Lovely.
And to echo on what Benedict just said to you, sorry for the sound. Of course, by putting the lead in parallel of the nerve, you got much more combinations and a field of stimulation which is more accurate. But the advantage by crossing the nerve, for example, for the plexus, is that with one lead and only in 4 contacts, you can have different routes. So you can have C5 and C6 with one lead and only by crossing the fibers. You're welcome.
Any other questions? Something to add? Everyone happy? Well, if some questions are coming up, you can to the booth later.
Thank you very much for the presentation. I think we all know that ultrasound, 2 big difficulties are the bone and other tissues like metalwork. I've seen lots of patients with back pain having metalwork and with radicular pain. So I was wondering if you have any tips or things how best we can do. I mean, I love the technique, having ultrasound and live vision. Probably that's where the future is going. Yeah, thank you.
Yeah, I think you're totally right, and we are aligned with you. And at the moment, there is an interesting concept maybe to share and to work on together, is the fact that when you got somebody with a lot of instrumentation, I mean, very difficult access to the spine, the idea of performing extraforaminal approaches to put, for example, a DRG stimulation will be very, very interesting, is to treat spine by an out-of-spine approach in these specific cases. That's what we are working on with Benedict at the moment. You're welcome to join, to visit, and to work on that.
Well, tomorrow at the end of the day, I will give a lecture, a presentation about the endoscopy. So if you are interested, you can find me on the program. There I will show you, for example, it's mainly pain treatment. So with this instrument, I do the gordotomy, the percutaneous gordotomy. I do the trigeminal neuralgia, celiac plexus blocks, paravertebral blocks, you name it. You see the pleura, you see everything. So I think it's very interesting. And it is not only anesthesiologists who are enthusiastic. Orthopedics, they use it for a minor scopy of the knee. Genicular nerves are perfectly approachable. You will find them with the scope. You name it. So I hope that tomorrow, if you are not going out in this beautiful country, beautiful city of Paris, that you will join the things. Yeah. It's about 5:30. Yeah, 5:30 p.m. No, it's somewhere in the, I don't know exactly where it is. In one of those theaters. Yeah. Yes. Well, anyway, if some question is coming up, then I invite you to the booth to put your questions there in a personal way. Thank you for coming, and I hope you enjoyed it, and I hope you will be have the same excitement as I have. Yeah.